Okay. Welcome. We're excited to have you with us. Give it a few minutes for people to start rolling in. As always, I hope you're doing well on this Tuesday, beautiful fall Tuesday morning here in the amazing Cleveland, Ohio. And I know what it looks like in Connecticut because I got to see Mytien walking her baby yesterday and all the beautiful fall leaves. So we're both having a little bit of it looked like a Gilmore Girls set yesterday. It looks a little bit like that now. As you can probably hear, I am sick. I am just getting over the flu, and so I feel a lot better than I look and or sound. But just a little plug to be careful, wash your hands. If you so desire, wear a mask. And I did not get my flu shot in time, so I think I paid the price last week for sure. All right, we seem to have tapered off, so I'm going to get us started. Welcome to Dream Grand Rounds. It's, as always, my pleasure to host these, and we are so grateful to the University of Illinois College of Medicine, Department of Medical Education for sponsoring these. And today we'll be talking about race and disability characteristics as they relate to accommodation disparities on USMLE Step 1. My name is Lisa Meeks. I am the founder and co-director of the Docs with Disabilities Initiative, and I am a professor of medical education at the University of Illinois College of Medicine in the Department of Medical Education. And Mytien, you want to introduce yourself?
Hi everyone, my name is Mytien Nguyen. I'm an MD PhD candidate at Yale School of Medicine, and I have the privilege of working with Dr. Meeks and Dr. Boatwright in the DREAM and Prodigy labs, respectively.
Yay. So normally I would be introducing our speaker, but today I am lucky enough to be part of the conversation on a paper that was really important to me and is really important to many of you and to our learners. We have the names listed of all the authors here, and as always, at the in the Meeks and Prodigy Labs, we make sure to include individuals that are representative of the topic that we're researching. And so in this case, we do have medical students and admissions folks, things of that nature. So, all right, let's see. So I want to start just by acknowledging the growth in disability disclosure over the last 4 years. And so this is a snapshot. This slide represents a snapshot of the number of students in yellow that have disclosed on a double AMC survey. So it's self-reported data, and this is the number of students starting in 2021 and up to the most recent data we have of 2025 who have disclosed a disability of any category. Now, what's really interesting is that in the line below, the blue, or it may look even black to you, line, you'll note that these are the number of students of those who disclose disability who tell us that they have received accommodations at their institution. So there's a pretty wide gap, and it remains at about 50%. Unusually and concerning for our teams is the wider disparity in 2025. So we're starting to see perhaps less learners receiving accommodations for their noted disability. And when we look at categories of disability, and this is a snapshot simply from 2025, we note that there's differences in the types of categories that are presenting. So leading the pack really is ADHD. The majority of learners are telling us that they have ADHD, and psychological and chronic health are behind those. And then I'm noticing that the labels are not matching. So if you look at the left-hand side, I do apologize. These slides were just updated this week. And as I noted, I've been sick, so clearly an oversight on my part. But the number of individuals disclosing ADHD is at about 70%, and psychological disability dipped to below 20% alongside chronic health. What we also see is that learning disabilities, mobility, deaf and hard of hearing, visual disabilities remain in these very low representative numbers. And so that is also a concern on the part of our team. And we know that there are negative outcomes for learners with disabilities. So we know from research back in 2022 from our Pathways 1 study and now Pathways 2 as well, that the Step 1 and Step 2 scores for learners with disabilities are lower. We also know that there's an increased likelihood of taking a leave of absence, increasing time to graduation. We know that learners with disabilities are less likely to receive honoraria, honor society, placement that includes AOA and gold humanism, and they're less likely to match into some specialties. I'll turn it over to Mytien.
Thank you, Lisa. And from our prior research, we also know that students with disability face incredible barriers in medical education. So we were able to look at the first year of reported data actually from the WMC on discrimination based on disability. And we see that students with disability, between 5 to 10%, have reported significant discrimination based on denied opportunities, subjected to offensive remarks based on disability, and receiving lower evaluation or grades. And these percentages are significantly higher across specific disability type, including students who have chronic illness, as well as motor or sensory disability. And concurrently, we also know that these experiences of stress and discrimination can also lead to incredible burnout among trainees. And we've shown here that students with disability are significantly more prone to burnout compared to non-disabled students. And this gradient is more so for students with more than one type of disability. And when we look at this burnout by racial groups, we also see that this gradient is consistent across all racial groups, whether it's white, Asian, underrepresented in medicine, so Black, Hispanic, and Indigenous students, or other race ethnicity. So Lisa talked about disparity in regards to induction into honor society, leave of absence, and time to graduation, and disparity in match grade. Students with disability are more likely to burn out and face discrimination based on disability. And what do all of these outcomes have in common? Generally, what we've seen, next slide, please, is that upstream of these outcome is students' preparation and performance on the USMLE Step 1 exam, which is to many the first milestone in undergrad medical education. And students often take Step 1, pass or fail, as a indication of whether they'll succeed as a future physician. And so we are interested to delve deeper into the landscape of preparation and performance on Step 1 in general. And for students with disability, what we know from the Dream Lab that has previously published is that medical students with disability who were approved for accommodation on the NBME tend to score higher on an average of almost 6 points than those without accommodations. And 6 points might sound like such a small number, but it could be the difference between a pass and a fail as well. And so our research question is, we want to examine both individual and institutional aspect of the preparation for Step 1 landscape. And for students with disability, this is accommodation. And we know the importance of accommodation on performance. So we were really interested in whether there are significant difference in accommodation requests and approval rates on the USMLE Step 1. And whether this request and approval rate was associated with students' social demographic identities, including gender, race, ethnicity, the type of disability, timing of disability diagnosis, and also whether institutional resources like having a disability research professional influence or change the request and approval rates. And here, this is our paper that's published in JAMA already. You can read more details about it. We'll post the link in the chat. And in the next few minutes, I'm gonna quickly take everyone through the main, or what we consider the main and important findings. So aim of the study is to determine whether social demographic disability and institutional characteristics impact how the prevalence of request and approval rate for accommodation on step 1. So we're gonna look at gender, race, ethnicity, disability type, timing of disability diagnosis, as well as presence of a disability research professional. We are very glad to have a collaborative study across 9 medical schools. We were able to collect data on the aforementioned variables, as well as whether students are requested and were approved step 1 accommodation across these 9 schools for 3 graduating cohort from 2020 to 2023. So we had across these cohorts and these 9 schools, 295 students that identify as having a disability. And within this cohort, most were female, 64%, and only 36% were identified as male. So first we looked at request. Across schools, we see less than 1 in 2 students with disability requested step 1 accommodations, so only 41%. This rate actually varies significantly across schools. So across the 9 schools, the average was 34% request rate, but it ranged from 15 to 46%. And when we look at by social demographic characteristics and institutional resources, we saw a significant disparity across several identities, specifically by race ethnicity. We saw that there was significant lower request rates among Asian students, where only 20% of Asian students requested accommodation compared to 46% white students and 39% of URIM students. And as well, we also saw significant differences across disability type. Specifically, we saw that students with physical and sensory disability, as well as those with psychological disability, had significantly lower request rate at 16 and 30%. Respectively, compared to about 1 in 2 or 50% of students with ADHD, chronic health, and cognitive learning disability. And then finally, the last significant difference we saw was by timing of disability diagnosis. And this it was no surprise to us, actually, where we saw that students diagnosed during medical school had significantly lower request rate compared to students who were diagnosed with disability before medical school matriculation, so 25% versus 53%. We saw no difference by gender or whether the school had specialized DRP support. And then our second aim is to look at approval. So among those who submitted a accommodation request, how many of those were approved? Across schools, we were really excited to see that the majority, so 2 in 3, or 69%, were approved for accommodations. But we saw significantly that there is a wide range of approval rate across schools, from 13% at one school to 96% at another school. So this is a very, very wide range of approval rate. And so this is actually incredibly reflective of whether the school had DRP or disability research professional, where we saw that 78% of students that submitted accommodation was approved in school among schools with DRP, compared to only 53% of students the students in school without a DRP. We also, again, saw a difference across disability type, where students with ADHD and psychological disability has significantly lower approval rate. So only 1 in 2 of requests were approved for these students, compared to a very high amount, 92%, 84%, and 100% of students with chronic health, cognitive learning disability, and physical sensory disability. And then finally, we also again saw a significant difference for timing of disability diagnosis, where among those who submitted a accommodation request, only 43% of students that were diagnosed during medical school had successful approval of the accommodation, compared to 76% of students who were diagnosed before medical school. And here for approval, we didn't see any significant difference for race and ethnicity. I'll pass it back to Lisa for the main takeaways.
Thanks so much, Mytien. So, what did we take away as a team from this paper, and what do we think is important for you to know? Well, I think, especially given our emerging work on the impact of disability resource professionals in the space, I think one of the big takeaways is that where you attend school matters. So, I want to bring you back to the range that Mytien had shared with you about the number of people who were accepted, had their accommodation requests accepted. It was 13% to 96%. That immediately for us and for me as a researcher said there's something at the school level that's happening, right? Because you would think that the data would be spread out across all of the schools, and because this is collected in aggregate, we were looking and seeing lots of different types of disabilities in lots of different schools. But when we looked by school, that range just really hit home for us that there's something different happening. I think any student would say, I kind of want to be at the school where 96% of the students who apply for accommodations are getting accepted. And the interesting thing for us, although this isn't public information, we know which schools those are, and it did track with the advanced training and expertise that those disability resource professionals had in assisting learners in medical school. So the big takeaway here is having a specialized disability resource professional, somebody that has that advanced training, is really important, and important in many different ways. Allie, it'd be great if you could post Sarah Triano's latest paper from Academic Medicine that also talks about the impact of DRPs and the other impact that they have. So one of the findings that Mytien shared with you was the lower request rate for Asian students. And Mytien and I talked about this a lot. I mean, there's some cultural stigma that goes along with that, that is linked to societal inequities. And it may be that individuals of Asian descent have familial reasons for not identifying as disabled that also lend itself to delayed diagnosis or lack of resources that result in delayed diagnosis as well. The medical training related barriers we think that might be impacting this is lack of awareness. And this would be for a lot of students, students who are privileged or have been good consumers of accommodations in the past. In other words, they've had accommodations in elementary and high school and undergraduate, maybe more aware that this is an option, where students coming from minoritized backgrounds or first generation students may not be as familiar with this. And then the fear of disclosure, which we know from our other research is very, very real. Students tell us quite often that they do not disclose for fear of bias and stigma, lower ratings. And in that first slide that I shared with you, showing that almost 50% differential between students who identify as disabled and request accommodations from their schools, we know that many students aren't even requesting accommodations from their schools. Now, interestingly, in our sample, all of the students did have accommodations from their schools, which makes this even, I think, more robust of a finding. And then there are barriers to requests for all students, and these are really the same. No documentation, well, obviously cultural and familial belief systems, but also lack of documentation. This is one that we see people report in the AAMC survey, and also one that people tell us in our qualitative research is that they don't have the funds, the time, the other resources to get the level of documentation that's needed to substantiate their disability to the MBME. Also, related to medical training and related barriers would be lack of awareness. So, one of the things that we do hear students say is that while they knew they had to apply for accommodations for step one, they didn't realize they had to do it almost a year in advance. Other students will tell us they applied for accommodations, but were rejected and needed to appeal, which extended their timeline and they ran out of time without having to take a leave of absence. So, lack of awareness, fear of disclosure as well, the belief systems. This was a big one that we pointed out in our paper. There are some rumors out there, and one of the things we were most excited about with our paper is that we get to dispel some of these rumors. And the rumor is that no one gets accommodations on step one, and that is simply not true. While we found differences that need to be attended to, we show and we've known historically that students do get accommodations, but they really do need that support of a DRP, which brings me to the final one, which is lack of assistance. Many students told us there was no one to help them, no one to help them navigate the system, understand the document requirements, help them with their personal statements, no one to kind of alleviate the fear and reduce the concern about people finding out that you had accommodations or that you weren't going to get accommodations at all. So lack of that specialized DRP. And then barriers to approval. Some of the things that we think are really driving the differences and approval rates are belief and transparency. I don't believe, and Mytien, feel free to jump in, I won't speak for you, but I believe that many students still are not applying. And so I don't think that we have a good picture truly of the approval rate because I think so many people are dissuaded from even applying or overwhelmed at the thought of applying that they just don't bother. Delayed diagnosis certainly is a problem because if you haven't been a consumer of accommodations and haven't had a long history of diagnosis, you need to do more. The threshold is higher to prove that you are disabled and to prove that you have a functional limitation and a barrier related to this exam. So I think what we see in our data sets are that a lot of medical students have delayed diagnoses because they've been compensating for so long. And once they hit that medical school curricula, they're no longer able to compensate at the same level and wind up with a diagnosis. And that takes time. The lack of school level support. So trust me, I've seen the difference between a really well positioned and well developed application and a really terrible application that serves as almost evidence of not being disabled. So I think that that school level support, and it doesn't necessarily, I think, have to be a DRP. We have so many amazing learning specialists that can also engage in advanced training in this, but some sort of support to help the student put this together. Remember that the students are usually applying in second year when they're also doing a million other things and they have very little time to pull all of these things together. We really encourage people to encourage the learner to pull all the documentation together in year one when they have more time to do so. And then that fear of disclosure, I think it was maybe 3 months ago, it was so sad. We had a learner who said, well, I didn't want my scores flagged. Scores haven't been flagged in years. And so, again, it's the perpetuation of these rumors about step one and step one accommodations that simply aren't true. The MBME does not flag scores. No one is going to know that your test was accommodated. And also, people do get accommodations. Which brings us to, I think, the most promising finding from our research, which is that our findings showed that two of three students did get accommodations. Now, I will say it's kind of a Goldilocks syndrome. The previous research on the topic was showing less than or around a 50% approval rate. So we found a better rate than previous research. The MBME currently boasts an 89 or 90% acceptance rate, and we were not able to verify that or support that finding. But I do think that this approval rate is the highest we've seen in any empirically um, collated data. And so I think that's really important and really promising and actually is a lever and hopefully one that gets pulled with this paper to encourage people who are not applying to actually come forward and apply. So, when we think about reducing the barriers to accommodation requests and approvals, I talk about it in three buckets. I think that there are three different ways that we can do this. I do want to acknowledge that some of the barriers, the financial barriers, the cultural and familial barriers, the lack of access to documentation may be driven by things that happen very early in a learner's life and may be more systemic and are not the responsibility of the LCME or the medical school or the MBME or MBOME. Yet, I think we have a responsibility to look at those barriers, evaluate those barriers, interrogate those barriers, and see what part we can play in the solution. So for the LCME, one of the things that we talked about was this this specialized DRP role. The LCME doesn't have any requirements for you to have a DRP at all. Yet this is someone who has this advanced expertise and knowledge about not only disability law, clinical accommodations, but the MBME process. And we see time and time again in our research, and we've got more and more research coming out in 2026 that shows that having a specialized DRP, someone who's gone through this research, is measurably results in measurable differences for your learners. So it really is an investment in your program. I also think there are other benefits to it, like eliminating potential conflicts of interest by ensuring that accommodation decisions are made by more neutral professionals and you don't get in that conflict of interest zone that sometimes we see with deans of students or committees that are doing this work. And then for medical schools, we really encourage you to provide early identification of disability related barriers, really talking to learners, all of your learners about, disability and disability inclusion, encouraging people to come forward early so that you can work with them to collect that data, figure out if they need new testing, get them connected to resources, a specialized DRP, or someone specialized to support the MBME accommodation requests. I used to say when I did this for UCSF, as part of the wellness team, I would spend on average 12 to 15 hours with learners. I would get to know their history, the impact in school. I would help them pull together. I had a checklist for them where they pulled together all of their items. I told them very early whether or not their documentation would work for the MBME. We got them connected um, to people to do retesting if needed, and I helped them with their personal statements. And we had a 98% acceptance rate. So I do think having that additional support works. Speaking of needing new documentation, you should think about ways and opportunities for low or no cost screening and neuropsychological evaluation. At UCSF, we were lucky enough to have our student insurance pay for some of this testing, but I know some schools have connected with neuropsychologists who can do a sliding scale. They also some schools have PhD programs in clinical psychology where learners need to practice testing. So those are different options that you can look at and make sure that the person you're referring students to is familiar with NBME requirements and the rigor of the evaluation that's needed. I think broad and frequent dissemination of resources is important, reminding learners they have a lot on their plate. And when you tell them at an intake, before matriculation that they're going to need to do all these things for step one, they're very quickly inundated with lots of things and they need that reminder. Normalize discussions about disability. Disability should not be an bad topic in your medical school, and talking about it and normalizing it allows students to reduce that fear of bias and feeling like they might be assessed differently. And then provide, we've seen the differences for specific groups. So providing a vetted list of culturally humble diagnosticians that are familiar not only with MBME, but with medical students who come from minoritized and marginalized backgrounds who may not have this robust history of accommodation. And then for MBME and MBOME, a couple of recommendations. And we say MBOME even though we only looked at step one, because we actually hear the same concerns, barriers from students who are in DO programs. So this goes across both. To simplify the documentation requirements, it's a pretty high threshold. And what we see is learners who are being approved at the medical school level and not approved at the MBME level. And so at the very least, there should be some sort of parallel between these and an understanding by the learner if there are going to be different levels of decisions made. Provide clear application instructions, train staff on implicit bias and ableism. The most important thing, and I think the biggest thing that could be done is reducing that 60 business day turnaround. It is in and of itself a barrier for students because they don't know if they're going to have accommodations. That 60 days of not being able to have focused study in the same context and under the same conditions that they'll be having during their testing. It also delays their ability to register for the test, which results in all kinds of, like we said, the domino effect, all kinds of things, including not being able to find a testing center. And we encourage them, if they haven't already done this, we don't know, they may have already done this, to establish an advisory committee that's made up of DRPs, medical students with disabilities. We have a lot of student affairs deans who have concern about the number of barriers that are in place. So bringing in those folks from different groups to inform how to improve processes. And then what we see in the UK and in Canada is actually a beautiful model where the groups that are doing this level of board exam are actually reaching out and working with known researchers in the area, like the Boatwright Lab and the Meeks Lab, and working to go through their data and establish, some reporting on the actual data. Of course, we have a subset of data and anyone doing this work would be working from a subset. But the MBME and the MBOME have all of the data. So being able to work with people if it's a resource or a bandwidth issue, working with known clinicians and researchers in this area to advance and elevate the transparency of the data. I know that, for example, MBME recently did provide some level of data, but the data was not specific enough to really understand what's happening, especially by different disability category types, as we see in our data. And we have several references here for you, and we can arrange to share this once I update